This is Professor Capron. Welcome to this presentation on ventricular fibrillation. Let's take a look at the learning objectives for this presentation. By the end of this presentation, you will be able to understand the identification criteria for ventricular fibrillation on an ECG, comprehend the physiological mechanisms leading to ventricular fibrillation, recognize the clinical presentation and immediate medical management of ventricular fibrillation, learn the nursing interventions and post-resuscitation care for patients with ventricular fibrillation, and identify related conditions that can lead to ventricular fibrillation. These are the key terms for this presentation. Make sure you pause the video and get these marked down. If you still don't understand these terms at the end of this presentation, please make sure to see me in class. Ventricular fibrillation, also known as VF or VFib, is one of the most critical rhythms to identify on an ECG because it requires immediate intervention to prevent patient death. The hallmark of VFib on an ECG is chaotic, disorganized electrical activity. Unlike normal rhythms, there is no coordinated electrical signal that leads to effective heartbeats. This chaos reflects the multiple erratic electrical impulses firing from different areas within the ventricles. This disorganization means the ventricles are quivering instead of contracting in a synchronized manner. The absence of organized contractions leads to no effective blood flow, which results in the immediate cessation of circulation known as cardiac arrest. In a healthy heart, you would see distinct P waves indicating atrial depolarization, QRS complexes indicating ventricular depolarization, and T waves indicating ventricular repolarization. However, in VFib, none of these are present. The chaotic electrical activity disrupts the normal conduction pathway, so these waveforms cannot be distinguished. The lack of these identifiable components is because the heart is not going through the usual process of organized depolarization and repolarization. Instead, there is a continuous erratic firing of electrical impulses. The amplitude or height of the waves on the ECG in VF can vary widely. You might see some waves that are relatively high, while others are very low. The frequency or rate at which these waves occur is also irregular and unpredictable. Unlike atrial fibrillation, where there may be some degree of regularity in the erratic activity, VF is entirely random. This variability in amplitude and frequency is due to the lack of a single dominant pacemaker. Instead, numerous areas of the ventricles are attempting to initiate a contraction simultaneously without any coordination. Understanding the physiology of VFib is crucial for recognizing its severity and the urgency of intervention. In a normally functioning heart, the electrical impulse originates from the sinoatrial node, travels through the atria, passes through the atrioventricular node, and then spreads throughout the ventricles in an orderly fashion, resulting in coordinated contractions. In VFib, this orderly process is completely disrupted. The ventricles experience chaotic electrical activity originating from multiple ectopic foci within the ventricular myocardium. This chaotic electrical activity prevents the ventricles from contracting in a synchronized manner. Instead of effective coordinated contractions that pump blood, the ventricles merely quiver ineffectively. The quivering of the ventricles is insufficient to generate the pressure needed to open the aortic valve and push blood into the systemic circulation. Cardiac output is the volume of blood the heart pumps per minute. It is a product of the heart rate and the stroke volume. Effective cardiac output requires coordinated contractions of the ventricles to ensure that blood is pumped efficiently to the body and brain. In VFib, the disorganized electrical impulses result in the absence of effective ventricular contractions. Without these contractions, there is no stroke volume, meaning no blood is ejected from the heart. Consequently, there is a complete loss of cardiac output. The body and brain are deprived of oxygenated blood, leading to rapid loss of consciousness and death if not immediately treated. The lack of cardiac output means vital organs, especially the brain, begin to suffer from ischemia in seconds, leading to irreversible damage if normal rhythm is not restored promptly. VFib is a medical emergency and one of the most critical rhythms to recognize and treat promptly. It is the most common arrhythmia in cardiac arrest situations. The immediate threat to life is due to the cessation of blood flow. Without intervention, VFib rapidly progresses to death within minutes. The urgency stems from the need to restore organized electrical activity and effective cardiac output to prevent organ damage and death. Urgent intervention typically involves defibrillation, the primary treatment for VFib. Defibrillation delivers a controlled electrical shock to the heart, aiming to depolarize all of the myocardial cells simultaneously. This can stop the chaotic activity and allow the SA node to reestablish a normal rhythm. CPR is absolutely necessary when performed immediately to provide artificial circulation and oxygenation until defibrillation can be performed. High-quality chest compressions help to maintain some blood flow to vital organs. ACLS, or advanced cardiac life support, includes the administration of medications like epinephrine and antiarrhythmics, advanced airway management, and continued defibrillation attempts if the initial shock does not restore a viable rhythm. Let's take a look at the assessment and presentation of VFib. Patients in VFib are typically unresponsive. This is due to the sudden loss of cardiac output, which leads to inadequate blood flow to the brain, causing rapid loss of consciousness. Upon approaching the patient, you'll note that they do not respond to verbal commands or physical stimuli. In VFib, the heart's ventricles quiver ineffectively, preventing the generation of a palpable pulse. The absence of a pulse is a critical indicator of cardiac arrest. Pulse checks should be performed quickly at the carotid or femoral arteries, as these central locations are more reliable in critical situations. The patient will exhibit classic signs of cardiac arrest, including apnea, agonal respirations, cyanosis, and dilated pupils. Immediate recognition of these signs is vital for initiating prompt resuscitation efforts. Hemodynamic status refers to the blood flow and pressures within the circulatory system. In VFib, the chaotic electrical activity in the ventricles prevents effective blood ejection from the heart. This results in the absence of measurable blood pressure. Non-invasive blood pressure monitors will fail to detect a reading, and invasive arterial lines, if present, will show a flat line or extremely low pressure. Similarly, the absence of a pulse confirms the lack of effective blood circulation. Both radial and central pulses will be non-palpable. The absence of these vital signs underscores the urgency for immediate life-saving interventions. On ECG, VFib is characterized by rapid, erratic electrical impulses that lack any organized rhythm. There are no distinct P waves, RS complexes, or T waves, making the tracing appear chaotic and disorganized. The amplitude and frequency of the waves vary, reflecting the uncoordinated contraction of the ventricular myocardium. Continuous ECG monitoring is crucial. It's going to help us to confirm the diagnosis and guide resuscitation efforts. The real-time display allows healthcare providers to assess the effectiveness of interventions such as defibrillation. Recognition of VFib on ECG should prompt immediate defibrillation attempts, as this is the definitive treatment to restore a viable heart rhythm. Once VFib is identified, the priority is to initiate cardiopulmonary resuscitation, maintain some level of circulation and oxygenation until defibrillation can be performed. Remember, the key thing to remember with VFib is to defib. For VFib, you defib. Okay? Defibrillation involves delivering an electrical shock to the heart to depolarize the myocardial cells simultaneously. This aims to stop the chaotic activity and allow the heart's natural pacemaker to reestablish a normal rhythm. The effectiveness of defibrillation decreases with time, making it critical to minimize any delay. High-quality chest compressions should be performed at a rate of 100 to 120 compressions per minute with minimal interruptions. This helps to maintain perfusion to vital organs. Adequate depth and recoil of chest compressions are essential to maximize blood flow. Advanced cardiac life support includes the administration of medications such as epinephrine to increase coronary and cerebral perfusion pressure, and antiarrhythmics like amiodarone or lidocaine if VFib persists after defibrillation attempts. Airway management, including ventilation support with a bag valve mask or advanced airway devices, is critical to ensure oxygen delivery. Now let's look at the medical management of VFib. Defibrillation is the most critical and effective intervention for VFib. The goal is to deliver an electrical shock to depolarize the heart muscle all at once, stopping the chaotic electrical activity and allowing the heart's natural pacemaker to reestablish a regular rhythm. Use a defibrillator, an automated external defibrillator, an AED, Place the defibrillator pads on the patient's chest, one pad below the right clavicle and the other at the left mid-axillary line, approximately at the level of the fifth or sixth intercostal space. Ensure that no one is in contact with the patient or the bed to avoid accidental shock. Press the Analyze button if using an AED, which will assess the rhythm and advise if a shock is needed. Deliver the shock as instructed by the AED or manually set the defibrillator to the appropriate joules if using a manual defibrillator. Immediately resume CPR after the shock and continue for 2 minutes before reevaluating the rhythm. Defibrillation is essential because it can convert the chaotic rhythm of VFib to a normal rhythm. Early defibrillation significantly increases the chances of survival and successful resuscitation. While defibrillation is being set up or between shocks, CPR should be performed continuously to maintain circulation of blood and delivery of oxygen to vital organs, particularly the brain and the heart. Perform chest compressions at a rate of 100 to 120 compressions per minute with a depth of at least 2 inches for adults. Allow complete chest recoil after each compression to maximize venous return to the heart. After every 30 compressions, provide 2 rescue breaths if an advanced airway is not in place. If an advanced airway is in place, provide continuous compressions with 1 breath every 6 seconds. Minimize interruptions in chest compressions. Pause only briefly for defibrillation and airway management. Effective CPR helps to maintain a minimal level of blood flow to the heart and brain, improving the likelihood of successful defibrillation and reducing the risk of permanent brain damage. We're also going to be looking and going through the Advanced Cardiac Life Support, or ACLS, algorithm. So, medications are used to enhance the resuscitation efforts and improve the chances of returning to a normal rhythm. For epinephrine, you're probably going to be administering 1 milligram intravenously every 3 to 5 minutes during resuscitation. Epinephrine increases coronary and cerebral perfusion pressures by vasoconstriction. Then you'll also be using amiodarone or lidocaine. These antiarrhythmic medications may be given if VFib persists after the first shock. Generally, an amiodarone dose will be 300 milligrams IV push for the first dose, followed by 150 milligrams if needed. The lidocaine dose is 1 to 1.5 milligrams per kilogram IV. You need to make sure that you've secured an airway and provide ventilation because airway management is crucial for ensuring adequate oxygenation and ventilation. Initially, use a bag valve mask to provide rescue breaths. Ensure a good seal and deliver breaths that make the chest rise. If the patient remains unresponsive and resuscitation efforts continue, consider the placement of an advanced airway such as an endotracheal tube or laryngeal mask airway. This allows for more controlled ventilation and minimizes the risk of aspiration. Once an advanced airway is in place, provide continuous chest compressions and ventilate at a rate of 1 breath every 6 seconds. That's 10 breaths per minute. Medications like epinephrine help to improve perfusion pressures, while antiarrhythmics can help to stabilize the heart rhythm. Securing the airway and ensuring adequate ventilation are vital for maintaining oxygenation and preventing hypoxia during resuscitation. As the nurse, particularly as a new grad nurse, you are not going to be running these codes, but you do what to expect the providers to order. Now that we've reviewed medical management, let's look at nursing management. What are you supposed to be doing as the nurse? Well, start CPR right away. As soon as VFib is identified, or if the patient is found unresponsive with no pulse, initiate high-quality CPR without delay. This action is vital for maintaining blood flow to the brain and vital organs. Ensure that compressions are deep, at least 2 inches for adults, and at a rate of 100 to 120 compressions per minute. Allow complete chest recoil between compressions to maximize venous return. Minimize any interruptions to chest compressions. Only pause briefly for defibrillation or airway management. Continuous high-quality CPR helps to preserve brain function and increases the chances of a successful outcome when defibrillation is performed. Effective CPR can double or even triple a patient's chance of survival. You're also going to prepare and assist with defibrillation. So quickly retrieve and prepare the defibrillator. Ensure that pads are correctly placed, one below the right clavicle and the other at the left mid-axillary line. Confirm that all team members are clear of the patient before delivering a shock. You may be asked to set the defibrillator to the appropriate joules. For biphasic defibrillators, the initial recommended dose is typically 120 to 200 joules. And for monophasic defibrillators, it's usually 360 joules, but you're going to set it to what the provider says to set it to. If you're using an AED, you're going to press the Analyze button and follow the AED prompts to deliver the shock if advised. Immediately resume CPR after delivering the shock, regardless of the outcome of the defibrillation. Do not check for a pulse or rhythm immediately after the shock. Continue CPR for another 2 minutes before reassessing. Defibrillation is the definitive treatment for VFib. The goal is to stop the chaotic electrical activity, allowing the heart to reestablish a normal rhythm. There's some emergency medications that you're going to be told to give. Epinephrine, you're going to be asked to administer 1 milligram IV every 3 to 5 minutes during CPR to increase coronary and cerebral perfusion pressures through vasoconstriction. You may be asked to give amiodarone or lidocaine. These antiarrhythmic drugs can be given if VFib persists after defibrillation. You might be giving magnesium sulfate if torsade de pointes, this is a type of polymorphic ventricular tachycardia, is suspected. Medications support the return of spontaneous circulation. That's called ROSC, return of spontaneous circulation, by optimizing heart rhythm and blood flow. After ROSC, continue to monitor the patient closely for signs of a recurrence of the VFib or other arrhythmias. Continuous ECG monitoring is essential. Identify and treat any reversible causes of VFib, such as electrolyte imbalances, ischemia, or drug toxicity. Ensure adequate oxygenation and ventilation to prevent hypoxia. Consider advanced airway management if it's not already in place. Maintain blood pressure and perfusion to vital organs. You may need to use vasopressors like norepinephrine if needed. Monitor and manage potential complications such as myocardial dysfunction, acute kidney injury, or neurological deficits. Provide therapeutic hypothermia if indicated to improve neurological outcomes. Post-resuscitation care aims to stabilize the patient, prevent any recurrence of the VFib, and support recovery of organ function, thereby improving the chances of survival and better long-term outcomes. Understanding the conditions that can lead to VFib is critical for effective prevention and management. Myocardial infarction, commonly known as a heart attack, occurs when blood flow to a part of the heart is blocked for a long enough time that part of the heart muscle is damaged or dies. The damaged heart muscle from an MI creates an environment prone to electrical instability. This instability can disrupt the normal conduction pathways, leading to reentry circuits and abnormal automaticity. Scar tissue formation after an MI can interfere with electrical conduction, increasing the risk of VFib. The heart's inability to conduct electrical impulses correctly due to damaged or scarred tissue can precipitate VFib. Severe electrolyte imbalances are also a problem. Hyperkalemia can cause depolarization abnormalities, leading to widened QRS complexes and eventually VFib. Hypokalemia leads to increased excitability of cardiac cells and can cause premature beats, which may also degenerate into VFib. Magnesium plays a role in stabilizing cell membranes and regulating the movement of calcium and potassium. Low levels can increase the risk of arrhythmias, including torsade de pointes, which can progress to VFib. Electrolytes are essential for maintaining the electrical stability of cardiac cells. Imbalances disrupt the electrical gradients, making the heart susceptible to abnormal rhythms like VFib. Medications such as digoxin, tricyclic antidepressants, and certain antiarrhythmics can have proarrhythmic effects. Overdose or accumulation of these drugs can lead to VFib. Stimulants such as cocaine, methamphetamines, and excessive alcohol can cause significant cardiac stress and lead to arrhythmias. Medications that prolong the QT interval, such as certain antipsychotics, antibiotics, and antiemetics, increase the risk of torsade de pointes, which can progress to VFib. Understanding the potential for drug-induced VFib is crucial for preventing and managing this arrhythmia. Monitoring drug levels and being aware of drug interactions can help to mitigate this risk. Let's do a quick recap of everything we've learned. Ventricular fibrillation, VF or VFib, is identified on an ECG by its chaotic, irregular electrical activity. Unlike other arrhythmias, VFib shows no identifiable P waves, no QRS complexes, no T waves. The amplitude and frequency of the waveform vary randomly. The ECG looks like a series of erratic and disorganized waves. Can be described as just a bag of worms. VFib occurs due to chaotic and rapid electrical impulses in the ventricles, leading to ineffective contractions. The heart muscle quivers rather than contracts, resulting in no effective blood flow and cardiac output. Scar tissue from a myocardial infarction or other cardiac condition can create re-entry circuits, leading to VFib. Increased automaticity in the ventricular tissue can trigger VFib, and early after depolarizations or delayed after depolarizations due to electrolyte imbalances or drug toxicity can also lead to VFib. VFib is often associated with acute MI, severe electrolyte imbalances, and drug toxicity. VFib is a medical emergency that requires immediate intervention. Without prompt treatment, VFib leads to sudden cardiac arrest and death. Patients with VFib are typically unresponsive, pulseless, and show signs of cardiac arrest, and there is no detectable blood pressure or pulse. The first-line treatment for VFib is immediate defibrillation. Remember, defib for VFib. Defibrillation aims to restore a normal heart rhythm by delivering an electrical shock to the heart. While preparing for defibrillation, initiate CPR to maintain blood circulation and oxygenation. High-quality chest compressions and ventilations are critical for patient survival. Follow ACLS protocols, including the administration of emergency medications such as epinephrine or amiodarone. Secure the airway and provide adequate ventilation. And after successful resuscitation, closely monitor the patient for any recurrence of VFib. Manage conditions such as correcting electrolyte imbalances or treating myocardial infarction. Support organ function and provide comprehensive post-resuscitation care. I'm really grateful that you spent so much time listening to this. Please make sure that you stand up, stretch, move around, get some of your own blood to your brain. And when you're done with that, go on, get out of here. Go do some nursey things.